today's episode, we're going to talk about HRT and hair loss. I'm Dr. Valerie Davidson from Progress Your Health.
And I'm Dr. Mackey from Progress Your Health. Hair loss is one of those things that comes up all the time. I know we got a couple of questions, sort of the same idea. Are you going to read them both or read the shorter one, then the longer one? How you want to do that?
We could go through both, but the reason we're doing this one is we get this all the time about the hair loss and hormones and menopause and perimenopause. And then we had these great questions from YouTube, from the YouTube comments that I thought we could talk about.
Yeah, sure.
Okay.
So if you do have questions, which we encourage those, it gives us lots to talk about. You can, if you're watching this on YouTube, you can write your question in the comments below. And it's really been fun, seeing people actually respond to, we just started this YouTube channel not that long ago, and the questions are, there's a lot to go with on those questions for sure. Why don't you dive in?
I'm going to jump in. So this question or comment or concern is from @StayGold. I just started the estradiol patch 4 weeks ago with 100 milligrams of progesterone. I'm 56, and I skipped a couple of periods last year and a couple this year, then had one, then had two, but I've been losing hair terribly, and terribly is in capital letters. The last 2 years, and especially the last 6 months, I'm afraid I'm going to go bald. It won't stop falling out, and I think I'm converting something into testosterone because my testosterone is at 66 with chin hair, and I had acne from ingrown chin hairs for a while, and for about the last 2 years. So I had my labs checked in April. My estradiol was 115, but then in September is back down to 10. But like I said, the testosterone was at 66. My progesterone is at 0.4. I'm on 0.375 of an estradiol patch. So 0.375 of an estradiol patch and 100 milligrams of oral progesterone. And I am taking spironolactone every other night to try to stop the androgen production or conversion or to slow down my hair loss. It's absolutely devastating for me. I really wasn't having any hot flashes, but I wanted to ask my doctor for the patch, and she also started the spironolactone because the hair loss was actually my biggest concern. So let's see. And then she goes on to talk about that she also is using some vaginal estradiol on her face and a little estriol for a few months on her face, and the results are great. It looks amazing. The estriol helped clear up her chin acne and the ingrown chin hairs she was getting, but the hair loss won't stop. I don't know what to do. I've been using men's 5% minoxidil, which is like a Rogaine, which worked well in the past, but from severe hair loss that she had in 2015 over a death loss, and she's also using a red light hairband, but it looks like nothing is working. I'm very careful in not washing my hair all the time. I don't use lauryl sulfates, and I'm hoping that I might get my hair back. But the more I research this, it seems like I'm not going to, and I'm really depressed about it. Is there any chance that using this hormone therapy and the spironolactone will allow for my hair to come back? I literally have PTSD every time I go shower because of my hair loss.
Well, that's not something we've heard 1,000 times.
Yeah. That's why this one really jumped out, because I have people that say they're terrified to wash their hair. And I've even had patients show me, and they'll bring to me in little Kleenex baggies the hair that they lost from washing it that morning, just to, which I don't mind at all, but it really, it's really devastating for them. I have people take pictures of the hair that, when you wash your hair and you put it on the shower door or on the tiles, they'll take a picture of it.
That's what you do. You put it on the shower door.
Then I take it with a Kleenex and throw it in the garbage.
Not always. Sometimes you leave it there. That's okay. I'm just teasing you. The point is, though, some of the shedding is normal, right? Even your shedding, just as an example, seems like it's a lot of hair, but you don't seem to be worried about it because for you, that amount of hair loss for you is normal.
Is normal because I'm going to be 52 here, April 15th, my hair loss has not changed from as long as I can remember it. So I can understand, at Stay Gold, that maybe she was having a certain amount of hair loss, and now here she is, going into menopause, doing the hormones, and she's having more. Like, when your hair, when you're losing more than you normally have.
Yeah.
And then you can tell too, the little baby hairs aren't coming in, or you have little.
Oh yeah, you got a problem area. You have your hairdresser is saying something. Your friends or family are saying something.
The ponytail is a big one. People say I used to have a ponytail this big, but now I can wrap the elastic band around it another time. So I don't really notice too much of that because, well, want to brag, but I've had lots of hair, and I do a lot of things for it, and I do my own hormones, and so we work on that. So but you're right. I have long hair, so it looks like there's a lot when I wash it.
The hair is everywhere in the house. You don't need to take offense. I'm just saying, like I say, you got long hair and it's everywhere. My hair's blonde, so you couldn't see my hair. But I used to drive to California all the time, and my hair used to be inside the car all the time. It had a black interior, and there was always my hair was in the car because I spent so much time in it.
You have lots of hair. No one feels sorry for you. You have a ton of hair.
Well, so do you. You have a ton of hair.
But this is where at Stay Gold and other patients and other people we've talked to, this is a valid concern.
Oh, absolutely. There is not one thing. The two things that come up that are most distressing is the unexplained weight gain, or the perpetual weight gain, and the hair loss.
Yeah, with menopause and perimenopause.
Those are the two biggest things that, in some ways, are in a lot of ways, except since the GLP-1s are, the weight gain has been very challenging. I think GLP-1s are changing that. The hair loss one, that's still there's no quick fix remedy for the hair loss. That's a tough one.
No, but I think we can tease it apart a little bit too, and maybe come up with some. Because Stay Gold, you're not alone. If this is happening to you, this is happening to many, many other women. So there are some things we can do to explain it, and that's why we're here doing this podcast about HRT and hair loss, and also maybe some ideas to kind of circumvent that.
Yeah, I mean, you got a few things to consider. Hormonally, you got to worry about some things, both endogenous and exogenous. So what her body's making, what she's using exogenously, or hormones coming from outside the body. Certainly you have to think about inflammation. You have to think about her stress. She alluded to a couple things in there. Certainly even environmental issues, toxins of any sort. And even some of the products that people are using, all those factors have to be sort of taken into consideration when you're trying to, figure out it. And as well as I do, it's not usually just one cause. It is probably a combination of all those factors for her and for everyone else, in order to get to the bottom of, why this is even happening.
Well, let's talk about, we'll talk about some of the causes that we've talked about, like estrogen and progesterone. So menopause. Obviously, she's 56 years old. A lot of women that's going into menopause, they do notice that their hair starts to shed more. Yeah. And why is that? Because, of course, obviously the estrogen and progesterone have dropped down. But specifically is the progesterone, that usually drops first in perimenopause, like typically in your 40s. You'll notice that the progesterone drops down, and that usually causes the hair follicle to actually get smaller in diameter, so the hair that grows out of it looks thinner and it's not quite as strong or resilient. Now, when the estrogen drops, that turns off, I don't know what phase that is, the anaphase, the growth phase. So you have the progesterone drops, the hair itself gets thinner, each little strand does, so that's why the ponytail gets a little smaller. And then when they go into menopause, that estrogen drops, and that reduces the growth, so the hair starts to not grow as fast either.
So essentially they have less volume and no regrowth, right? Yeah, so they're sort of, that's why in her situation, she's sort of desperate to find an answer, because she's sort of having at least the coming out and not regrowing any new hair. Yeah.
But then, she said she's on hormones, which we'll get into a little bit about the patch and the progesterone. But you think about, too, that we've talked about before, is when the estrogen and the progesterone drop down, then the androgens start to come into play. Because we don't want to necessarily discourage the two main androgens in particular is the DHEA, which comes from our adrenal glands, and then the testosterone. And we, as females, make a little bit of testosterone from our ovaries, but we make a lot of it from the conversion of DHEA from your adrenals in the peripheral tissues converting to testosterone. And sorry.
You caught me there flat-footed. I thought you were going to keep talking.
I was going to keep talking.
I'm freaking out, like a deer in headlights right there. I wasn't sure what to do. I didn't think you'd come to such an abrupt stop. That's funny.
No, that testosterone. So testosterone actually will also further shrink in that hair follicle, on the head, and then that hair will comes out a little bit frizzier. Because even people will say, oh my gosh, I'm going through hormonal changes or my hormones and my hair is a little frizzier. Now, granted, if you've got a little bit of curly hair, then of course it might be a little more frizzy. That's normal to have curly hair. But if people notice I used to have really bone straight hair and now it's got this frizz to it, that's probably more related to those androgens, the testosterone and the DHEA. And you'll notice it too a little more up here in the temples, and then also on top of the head. Now, a lot of us, even me too, I have a little more
Or
You can see my temples.
and
It's
even
not
even the crown.
Yeah.
Kind of like more.
and that's normal, but you'll notice it more, more so when they hit menopause and perimenopause.
See, now that's the interesting thing, though. You would not expect a woman in her late 50s to be worrying about an increase in necessarily androgens. So she mentions her number, right? You and I we like the labs, we like the information. Her testosterone, she says, is 66.
Yes.
She doesn't mention in there that she's using any testosterone. So, and I know you and I were talking about this prior to, just to, kind of prep for this episode. Where do you think that increase in testosterone is coming from in a woman that's in her late 50s?
Do you think 66 is high?
For a woman who you and I have looked at thousands of labs over the years, right? The reference range, it is elevated on a reference range.
So
you just had yours done. Yours was what, 48?
Yeah. So just for background, so think Quest, LabCorp, all labs have different reference ranges for testosterone, for total testosterone. Free is different, but let's just talk about, she's talking about total testosterone. That's what a lot of doctors will test anyway. So the reference range for Quest, I think, is 2 to 45. I think LabCorp has theirs like 5 to 55.
I think it's 60.
Yeah, it might be 60. It's always changing. I've seen it different. But I would say for the most women that I've seen will usually be between 20 and 30. But now I see some other women higher.
Honestly, more like 15 to 25.
Yeah, I might see it. Yeah.
Very rarely do you see it consistently. You take a group of women, their testosterone is not going to be 25 to 30. Maybe it's going to be
25, 20 to 25, maybe up to 28. I see 32, 33. I don't see that often. 40s.
Now you see just as many that are in the single digits, that are actually really low too.
We see testosterone low all the time, and then that might be an indicator that we want to replace testosterone. But we're talking a little bit about, with that Stay Gold, her testosterone level is at 66. Now, like Dr. Mackey mentioned, I'm 52 years old. My testosterone, I think when I did it, was 48 this last January, 2025. So that's, normally I run a little higher on my testosterone anyway. Everybody's different. Some people run, I've seen some, and it doesn't mean.
But even your number, as an example, 48 is not a typical number.
No, it's not. And it
66 is even more of a non-typical number.
But it doesn't mean that I have PCOS. That just means my mother has higher levels of testosterone. When I've tested hers in the past, I have higher levels. So that's my genetics.
You were mentioning that because you're Okinawan, that there is at least a theory or a hypothesis that Okinawan women are by a population or a cohort, have higher DHA and testosterone levels.
That is true, and my DHA level is.
We got to find that study.
Yeah, I need to find that because I heard that. Gosh, that must have been like 15 years ago. I think I heard that there was something about Okinawan women and longevity and blue zone, and that they have higher levels of testosterone. It didn't mention about the DHA.
It was just testosterone.
It was just testosterone, but you figure the way women make testosterone, mostly, not all of it, is the conversion from your adrenal glands, DHA converting to testosterone. There's other means of making it through androstenedione, through your adrenals, your aromatase in your adipose tissue. So there's lots of other ways, but I don't know, it was a conference I went to, was mentioning that, and that stuck with me because, my mom's from Okinawa, which makes me half Okinawan. So, and her level, when I ran hers, and hers was post-menopause because she had never had her testosterone or any hormones ever checked. And when I did check it, post-menopausal, I think hers was elevated, and we kind of giggled, and I thought that was awesome.
Sure.
So that's a normal, but if, that's what I'm thinking with that Stay Gold, that 66 probably isn't her normal, but I will say it's not unusual to have higher levels of testosterone outside of those reference ranges, and they're perfectly normal. It just depends on the person.
Yeah.
Well, would you mind? Mine's on. I mean, if you were to check mine through LabCorp, it would be elevated.
Now, here's where the numbers. Yours is technically. Okay. Let's say LabCorp.
Quest, I think
it's
goes
2 to
45.
It's 2 to 45 or 7 to 45. So technically, on that one, yours would be elevated. I know they age adjust them, right? So at least DHA goes down as we get older, which in some ways is sort of defeats the purpose.
That's why you should never truly just look at those reference ranges. They're not set in stone.
Okay, so your numbers are elevated on one lab and normal on another lab, but you don't have any of the symptoms that would manifest or that would be indicative of having an abnormal testosterone number. So your expression of having a higher testosterone really doesn't manifest as anything. So for you, that number is clinically irrelevant for you.
Yeah, it's probably my normal. So, I don't have any breakouts. I don't have any hair loss. But let's say I checked.
And you're not growing any hair.
Yeah,
I don't see any hair in your chin or
Well,
anything.
we all have hair. We all have hair, but I don't have a ginormous amount. But, but at the same time, you think, okay, so I know my level right now. Let's say I checked my level and I'm 65 and it's a little lower, or I'm not feeling well, like I'm not feeling good. Then you checked it, it would be lower. That's why I always feel, and I'm totally getting off on a tangent here, that it's so nice to be able to check someone's hormone levels when they feel good, like maybe they're 35 years old or they're feeling good. You get their actual reference range, because I'm thinking, we don't know at Stay Gold, is 66 her normal? Probably not, but I have met a few women I can think of that is their normal and they're perfectly fine with it. But obviously she's not, because she's having the hair loss.
Yeah, well, from a even going back, like you're saying, like from a primary care medicine perspective, there's been this idea that you don't need to test a woman's hormones ever in her life. Right? And I think that's just sort of watching the reality of that and having all these women, they have no, like you just said about your mom, they have no idea what their hormone levels were. The other day I had a patient, and I have one that kind of relates to this one. We'll come back to that. The other day I had a patient, her estradiol, she's still menstruating. She's in her early to mid 40s, still having a period. And her estradiol she happened to go to the lab on day 13. It was either 12 or 13, which is a day that we like to send people to the lab, at least day 12. And hers was 441, and she was concerned because it had it flagged as being elevated, right? Now, granted, this is a little bit of a side tangent, but it just goes to show what kind of a range have you seen for an estradiol level for a woman on day 12? What kind of range have you seen for women that are still in menstruating age?
Oh, I've seen it go up, easily from 250 to 450. I think I've seen a couple of people, it was really high. Maybe we wanted to look into a little estrogen dominance for that, but it's not unheard of, because you're cycling, so those hormones change. But when you're not cycling, you're in menopause and the ovaries are not producing any hormones and you're not ovulating, then those levels are low.
Yeah.
I can understand that. The reference ranges, like I said, they're not set in stone.
But I've seen some, I remember there was one, and she was actually in her early 40s at the time too, and her estradiol was like 728.
Oh yeah, that's pretty high.
I've seen another one, but she had no symptoms. She was feeling great. I mean, a little bit of perimenopausal stuff, but no, as you say, kind of estrogen dominance, where you'd expect, heavy periods, heavy bleeding, fibroids. She didn't have any of that. Another one I saw was like 6 something. The one just the other day was 441. But it'd be really nice for a woman to know that when she's even a teenager, right? Teenager, 20s, 30s, you have this trend of what those numbers look like. So by the time you get to menopause, you can actually remember that, I felt really good when my hormones were in between this range. My estradiol on a day 12 should be about this. And then, I think it's worthwhile information as opposed to saying, we don't need to ever look at your hormones. It's not necessary, because it changes all the time anyways. So there's no reason to test for it. I think that's a little bit, a little bit of an old school way of thinking.
Yeah. So with Stay Gold at 66, we're thinking maybe, she's even saying, oh, well, maybe something's converting. Maybe it's not even her testosterone. It could be stress. Do you think it's the testosterone?
Well, that's what I'm honestly, based on her situation, if she was 20 years younger or still having a cycle, we just assume that she was a kind of a PCOS candidate, right? That she's on a spectrum of, having an elevated DHT or testosterone. That's going to be your first assumption. Now, granted, she just stopped her cycle not that long ago, so maybe there's a little residual PCOS going on there. You think that's possible?
I don't think it's anything to do with PCOS, because she would have known if there was PCOS well before she went through menopause.
Are you sure?
I am. I do. I think for her, she's going through menopause. That testosterone level, maybe, I'd like to go into maybe why it went up, because she's not taking testosterone. If anything, she's taking some spironolactone, which spironolactone actually blocks testosterone. You can lower testosterone by using spironolactone. She's using it every other night.
Men wouldn't really want to take testosterone or spironolactone.
But the spironolactone may help her, because she's looking at it, they're looking at it in the way of DHT, which is dihydroxytestosterone. So testosterone can convert over to dihydroxytestosterone, DHT, and that causes hair loss. Now, what other reasons would cause her DHT to come up? Having high levels of testosterone, having actually low levels of sex hormone binding globulin. That's something that we've talked about before. So sex hormone binding globulin, having lower levels is not a great idea. Having high levels is not a great idea. So let me back up here. So if somebody has high levels of sex hormone binding globulin, it will bind their testosterone, which will reduce to DHT. But it unfortunately will also bind her estradiol and reduce her estradiol absorption. So in some respects, now that I'm saying this, her sex hormone sex hormone binding globulin might actually be low, which is not binding that testosterone and causing DHT to go up.
Yeah, but she's also using the patch. More than likely, if she's using the patch, I'd like to, I don't prescribe the patch. And there's a few reasons why we don't prescribe the patch, and maybe this might be one of them, just in general, not saying, but just saying. That if she was using an exogenous hormone, more than likely and because she's in her late 50s, her SHBG is going to be elevated as opposed to low.
That's what
men and women are going to,
what I see.
Their SHBG is going to go up.
And you want to try to bring that sex hormone binding globulin down. So that was one theory I was thinking, because she's doing the minoxidil, which I've seen that work, doing the foam on the hair, on the scalp. I've seen that work. I've seen spironolactone work really good with helping with hair loss. But she said, she's having this terrible anxiety that to even shower because of the hair loss is, I wonder if maybe it might be coming from some other factor like cortisol.
Well, that's the unsung hero. So here's not it's a hero in this, it's the villain in this context, right? Yes. I think cortisol, as far as what everyone knows about cortisol, it would always, granted, it's necessary for life. We can't live without it. It's a very important hormone, but it always gets sort of a bad rap. And I think in this case, I think you're totally right. I think that the cortisol, and in her situation, the more time goes forward, the more stress she has, the more cortisol she's producing. It sounds like there's a death in the family, so there's probably even a higher peak of stress at some point.
Several years ago.
Yeah, and now it's just perpetuating, and now that's turned into perpetual hair loss. That's a really vicious cycle. How do you break that vicious cycle?
Well, part of it is, like, if she's scared that she's losing hair, her cortisol's up, and she's super stressed about that.
And she gets a reminder every time she looks in the mirror.
Yeah, that would propagate the whole system.
That's what I'm saying. Yeah, it becomes a little bit of a vicious cycle, cortisol on top of cortisol. And now, we attended a continuing education meeting this summer, and this last summer, and they were talking about hair loss. Of course, we attended because you're always trying to look for some clinical pearls. And the presenter was saying that there is, and I noticed this more directly during COVID, that because everyone, I'll come back to that in a second, that there's a 90-day delay to stress. So your stress peaks out, 90 days later is when you notice the increase in shedding. Sounds like in her case that it's been going on for quite a while. There's no real end in sight to it.
Mm-hmm. So she's mentioning, 2 years, the past 6 months, it's been really bad. So it could be just the stress having the higher levels of the cortisol.
Yeah. Now, physiologically, this is just for something you and I to chew on, right? Just because that we like those numbers and always trying to figure out the physiology, what's going on there. So do you think that cortisol directly, that stimulation directly increases the testosterone? Okay. Now, we have seen in the past when a woman is in perimenopause, they do get a slight rise, or at least they can get a slight rise to their DHA and testosterone as they're making that transition, right? It's almost like a buffering system as they're preparing for menopause. Do you think it could just be that in response to an acute stressor, why those numbers are propped up?
I know the body, because it knows that it's under stress, to try to have enough, cholesterol, enough hormones to provide cortisol. Like the androstenedione goes up. I think the DHEA can go up because the body's under stress, which then that would make the testosterone go up, which would then make the DHT go up. So I know the body is looking at it differently when it's under stress because it just wants to preserve life. So that's what I'm thinking, maybe, because also estrogen buffers cortisol. That's why part of the weight gain factor in menopause is when the estrogen drops, it can't buffer cortisol. So estrogen doesn't directly or indirectly cause weight gain or weight loss. It doesn't directly cause weight gain or weight loss. It indirectly does it by buffering cortisol.
Yeah.
So if the estradiol is dropped and the cortisol's high because she's stressed out, then it's going to have a further effect on, all the weight gain and hair loss, I would think.
Oh yeah. Yeah. I mean, that's why it's a really, it's really convoluted. Now it's easy to say stress, but then, from a treatment standpoint, what kind of relief
Think about what kind of stress. Mental stress, maybe people not sleeping. If you're not sleeping, that's a stress.
Well, you can have mental stress, you can have physical stress, you can have a lack of sleep stress, you can have
pain,
dietary stress. I mean, there's lots of different types of stresses.
Even people that are training for a marathon or a triathlon or changing their exercise to be more intense, that's a physical stress that can have an impact. So there's a lot on there. And you mentioned lifestyle too. What about nutrition? Nutrition can have a huge effect on hair loss.
Sure. Again, we're talking the three big things. Now we're talking estrogen, progesterone, androgens, and insulin sensitivity, right? And maybe four. So estrogen, progesterone status is going down because she's in menopause. Androgen status, we do know at least testosterone is elevated already. Cortisol we know is elevated just because of the circumstance, both leading up to and present. And we don't know insulin status. Okay? Insulin in this context, insulin sensitivity or insulin resistance is going to drive, in some ways, some changes that happen to the scalp, maybe a lack of blood flow. You throw some cortisol on top of that, and now it is just a runaway train. You're not going to be able to, corral that, that shedding and getting any regrowth. It's going to be a challenge for sure.
And then just your typical iron. So if somebody's anemic, that can cause hair loss. But she's probably not, because she's probably not bleeding. But ferritin is a protein. It's not a mineral or anything, but ferritin is a protein that binds to iron. So it kind of gives you an idea of your iron savings account. Now, ferritin is also an inflammatory marker. So teasing that apart, you have to look into that. But if somebody has a low ferritin, especially, under 50, especially under 25, then that usually means that's going to cause some hair loss, or that could be a contributing factor.
It could be definitely a contributor.
So I would check her ferritin levels. Of course, just minerals probably in general,
minerals across the board. I think
vitamin D.
Yeah, I mean, certainly nutrient-wise, there's lots of things, but even that, hormonally, there's a little picture there that is more than likely the driver of that situation. You and I were talking earlier. Can that? And you said no definitively. Can that patch, the estradiol patch, can that be converted into testosterone?
The aromatase. Testosterone can aromatize to estradiol. So testosterone can turn into estradiol, but I don't think there is a way. It's not a direct way to go back. Like estradiol does not turn into testosterone, but testosterone can turn into estradiol.
In women. In menstruating women, that's what essentially PCOS. You can go from estrogen to testosterone. Men go from testosterone into estrogen.
I don't know if it's directly. It might be by pathway of androstenedione, which is secreted from the adipose tissue, or from estrone. But I don't know if it's a back and forth road for testosterone turning into estradiol.
Well, isn't that so? When we were prepping for this, 5-alpha reductase is the enzyme. I think you can aromatize in both directions. You can aromatize estradiol to testosterone and testosterone to estrogen. I do think, because those two molecules are very similar in chemical structure.
They're almost like mirror chemical structure. I think there's a hydroxy group or carbon or something.
We took this this little thing here as kind of like the main structure of estradiol. We took that for a reason. Testosterone testosterone is missing one of those double bonds and has like a double OH off the end of it. Otherwise, the two molecules that's way more information than anyone cares. But that's where we came up with that little thing, because it's literally part of the estradiol molecule. And the testosterone piece, the only difference, I think there might be two actual differences, but otherwise they're sort of identical chemical structures.
Because that's where I feel like the patch, like I might not know completely that chemistry and which way it's going this way and that way, but I do feel like that estradiol patch is probably having some contributing effect on this. I had
another patient not that long ago, and she in Southern California, and she had left, and she sort of begged to come back because she was doing something similar and had exactly the same problem. She was not having a lot of hot flashes or night sweats, never really did, but she said the hair loss was terrible. was absolutely terrible. That's also why we're answering this question. And of course, you and I don't prescribe the patch, so
we can, but we don't, because it's just not a very good way of fine tuning the hormones. And it's interesting you say that. I had a patient recently, and they were looking at it. She's on 0.375 milligrams of an estradiol patch, and they were her and her doctor were trying to do this math, and not because 0.375 milligrams of an estradiol patch is completely different from 0.375 milligrams of like a biased with an estradiol and estriol. Yeah. Like they're just
the math
like
does
apples
not work.
and
when you're
apples
trying
and
to compare that patch to any other form of hormone,
so much stronger.
It's just so different. It's not even like the same thing. There's no way that patch, when a woman applies it on her skin, every 3 days, that they're getting 0.0375 milligrams.
There's something with the absorption, because when you test their blood, it might be up there at 111.
Well, she said when she had it on, it was 115.
Yeah, where if I gave a woman a biased or even an estradiol cream transdermally on her thigh of 0.375, it would never go to 111.
It wouldn't even go above 10. If her level, if she's menopausal and her level, it would
maybe kind of 20, maybe in the 20s.
No, it wouldn't even move.
30s.
It wouldn't even move.
So that's what I'm saying. There's something with that patch, but there is something there with that testosterone. And like we had, hey, she's getting her blood drawn. She probably should have her DHT tested.
She should have a DHEA sulfate tested. She should have a DHT tested. I don't think there's any value in testing androstenedione.
No, but the sex hormone binding globulin.
Sexual hormone binding globulin could be good. Honestly, even because her testosterone is elevated, I would do a DHT and a free testosterone. Doing a free testosterone in a woman, I don't really think provides a lot of value. And just in general, you're really more concerned about the total. Is the total less than 10, or is it, like you said, 20 to 30? Yeah. Okay. And if we're going to address it anyways, the free testosterone at that point really doesn't mean too much. For men, free testosterone might mean a little bit more, but it still really depends on what their total is. If a man's total is 250, well, you can assume what their reference range for men is going to be 250 to 1,000. If their total is 250, then you can assume that their free testosterone is not going to be very good, right? You could also probably assume if they're in their 50s, I'm 50, I'll be 51 here soon, that their their total testosterone, if that's low, then their free testosterone is low, then their SHBG would be elevated. I mean, it's easy enough to test all them, but for a woman, there's only some cases where it's actually really necessary, where it's really going to only provide you some useful information. I think in her case, it certainly could.
So, let's say it is the DHT.
Yeah.
The spironolactone, that's one way, that's a medication that's prescribed that she can take. And the minoxidil, the foam.
Say it again. The spironolactone.
What other DHT blockers, like Chrysin? Chrysin's you could use Chrysin to help block the DHT.
Saw palmetto is, of course, is the best.
Oh, yeah, saw palmetto. Even though if you look up saw palmetto, it says for your healthy prostate, and us ladies don't have a prostate. Yeah. That's because, but it does the same mechanism that causes a man's prostate to grow, which causes women's
so we
hair
use
to fall out.
We use a product that actually is for prostate. But if you look at some of the other ones that are online, they're called DHT blockers for women. It's pretty much exactly the same thing.
What other things could she use? So saw palmetto, I'm thinking Chrysin, DIM. DIM and 3-indole-carbinol?
I think DIM is going to be more on the estrogen side. I don't think that's really going to have too much 5-alpha reductase. Yeah. That's the enzyme that we're talking about. Testosterone to DHT, 5-alpha reductase is the enzyme. That's the aromatizing enzyme that's going to convert all those. That's why the saw palmetto, you're blocking the 5-alpha reductase, so it's going to block the conversion from testosterone to DHT. Most men probably want more DHT, right? They'd probably feel better if they had more DHT because it's a stronger form of testosterone. For a woman, if we assume that, or we know that her total testosterone is 66, then we could assume that her DHT is probably elevated.
Yeah, so maybe some saw palmetto. What about nettle? I've had some results here and there with nettle.
Yeah, sure. Yeah. I mean, anything that is in those quote unquote prostate formulas, you could probably use almost the entire list.
But maybe even raising it up, like the saw palmetto, doing a good dose. So I'd say probably the saw palmetto and maybe doing the spironolactone every day. You got to be careful with spironolactone because it's dehydrating.
It is a diuretic
by nature. It
can
lower your blood pressure.
Right? Yeah.
So you have to, and sometimes that's why I'll have women do it at night so it doesn't lower their blood pressure too much during the day. But then, of course, sometimes because it's a diuretic, it's like a water pill. They might be going to the bathroom all night. So you have to, so that, that's one of those things you have to balance with. But like saw palmetto and doing some other, DHT, like the chrysin. Chrysin is one I actually use a lot with men.
But chrysin, you're going to use more from the blocking the aromatase the other way.
That's true.
Of testosterone into estrogen. That's why men would take DIM or chrysin, because if you're giving a man testosterone, if you give them a high enough dose, their estrogen levels are going to go up. I don't see too many men. They talk about it, like andropause. You see all these men that have high estrogen. Maybe in a pre-diabetic or actually in a diabetic, you might see a man with abnormal estrogen levels, but it usually only happens once you give them the testosterone, then their estrogen level goes up. But then you give them, like you said, give them DIM or chrysin, and then they're, that's sort of the same thing as a Remedex, what a Remedex does. And I know you know that. I'm not telling you that, but the Remedex will block that same enzyme, and then you'll push it back towards testosterone as opposed to converting into estrogen too much. No man wants a high level of estrogen.
I'm thinking about, the patients that we work with hair loss, maybe even having her check her insulin levels, fasting insulin levels.
Yeah, I think that's sort of one of the bigger pieces, just in general, stress level, which is hard to deal with. But from our perspective, there's no medications you can prescribe for stress, right? There really isn't. And,
not that would be good.
Well,
you don't want to do a benzodiazepine.
Antidepressants and benzos, those are not what we're talking about, but things that actually support adrenal function. So all of the adaptogenic herbs, holy basil, licorice, ashwagandha, all those
rhodiola,
different...
rhodiola, I really
anything
like.
You can think of that would be used for the adrenals would be potentially helpful in a situation like this. And other things, there's even some meditation and breathing techniques you can do to lower cortisol. That's a really big deal. Insulin plays, if your insulin is out of whack, your cortisol is out of whack. If your insulin status, so fasting insulin should be under 10, ideally under 7. If your insulin is higher than that or in the double digits, then we can assume that your cortisol is sort of bouncing all over the place too. And whether that's from lifestyle and or from stress, it's going to have can have potentially a negative impact both on the waistline and on the hairline. In some ways, maybe I just sort of thought of that. It's making your waist bigger, and it's making your hairline, I guess, bigger. or reducing or receding. Because I even know some guys, always wondering why it can't be the same mechanism for men losing their hair, right? Because if men lost their hair because of high testosterone, then every 18-year-old or every 16-year-old would have a hair problem. They don't have prostate issues. They don't have hair problems. Those don't come until later in life. Now, some men lose their hair relatively. I think your dad is even saying he started losing his hair in high school.
Oh, yeah.
Yeah. But now he's a diabetic, so maybe there was an issue there even early on that sort of gets overlooked until there's a different diagnosis going on. I think insulin resistance is a big one. So if she's listening or paying attention, or anyone out there, if you're dealing with some hair issues, male or female, to be honest, I would get your insulin status looked at. Most conventionally minded doctors are not going to check your insulin status. So you sort of have to ask, check my fasting insulin to see what his blood sugar isn't enough. You need to look at that other level. I was doing some research on this. I just hit the microphone, so hopefully that wasn't too annoying. Also looking at some of those inflammatory markers. You mentioned ferritin. What about C-reactive protein? Do you think that would, I saw it in one of the things we were reviewing.
I've had several people I can think of with high CRPs, but I haven't really seen the correlation with the hair loss.
Yeah, maybe it just means
I
inflammation in general, like a
inflammation.
highly sensitive CRP. It just lets us know that there's something going on, but it might not be directly, because there's plenty of women that are losing their hair and their CRPs are fine.
And we forgot about thyroid. I mean, thyroid was probably number one, checking the thyroid. When you go through menopause or perimenopause, you will see those thyroid levels start to, or thyroid function decline a bit. So checking, because low thyroid will cause shedding all over, where more the testosterone androgens would be more in the temples and the top of the head. So if it seems like it's like all over, that would definitely, not just checking a TSH, but also your free T3 and the free T4, but the free T3.
Yeah, and screening, making sure those nowadays people are pretty up to date on the Hashimoto antibodies. Any kind of an autoimmune potential there is going to just increase the likelihood. But that's why this one is so interesting, because because of where she is. It's not now granted, hair loss and menopause sort of go hand in hand, but her numbers, at least that what she provided, do kind of make you scratch your head a little bit.
And I will say, I know she said she was doing her research, and she said, well, doing my research, it looks like my hair's not going to grow back. The hair follicle isn't dead. You both have seen, once you kind of work with the hormones or doing some things, you can grow the hair back. You can get that hair follicle to grow back. Now, if it's actually dead because of whatever reason, maybe genetics has an effect on it. But, I wouldn't say she's at the point of no return or it's irreversible.
Yeah. Yeah. Maybe that's where potentially another form of hormone, a route of hormones might not be a bad idea. A transdermal biased,
I would even do so she's doing right here, she says 100 milligrams of progesterone and the estradiol patch. So I'm thinking she's probably getting these more conventionally. So she's probably on a Prometrium, which is an instant release progesterone, which goes right into your system. And then like all progesterones, it's supposed to, come out by the next morning. But when I use a sustained release, it stays in your system throughout the entire night, but you want it to be a little bit lower in the morning so it's not making you tired or groggy during that morning time or that afternoon. But I have seen the sustained release have a really good effect with the hair, because progesterone is like the unsung hero of the hair.
Sure. Yeah. I mean, honestly,
really
women that are, still cycling, you can't give them estrogen, right? But progesterone with a thyroid can sometimes be very helpful, in managing that, that excessive shedding and getting some of that regrowth for sure.
And it looks like, this is just Stay Gold, but other people too. She is, had a couple of periods here, a couple of periods here. Sometimes that estradiol patch, because of the strength there, if you have a uterus, it can cause uterine bleeding. So you need to raise that progesterone up higher to offset that. And she's only at 100 milligrams.
If those cycles happen while she's on the patch, that's a whole nother issue that we talked about before about, HRT and bleeding, because, we don't want that number on any kind of static dosing. We do not want that number to be above 100, because it's just a matter of time before she either does get some bleeding or that lining is going to thicken. And then now not only is she losing her hair, but now she's putting herself potentially at risk over time anyways. So that's why these are helpful, because there's always things to parse out. There's always little different aspects. There's not, that's why hormone replacement can be challenging, because there's not just a, couple of medication doses you can pick up and, prescribe this and it solves the problem. It's a lot more complicated than that. And even hers with the, I'm still, sort of fixated on that high testosterone. Like it doesn't matter why it's high. I mean, it does matter why it's high, but why would it be high? Why would it be, now, granted, that's not a zebra of any sort. We've certainly seen numbers like that over the years, but it's still, she's having this hair issue, her testosterone 66, there's something driving that, hopefully figuring out what that is, and hopefully there would be some success. And once you clear out that hormonal, complication, now the regrowth can actually start to resume. And of course, we didn't mention, but, we were talking about adrenals, but of course, all the anti-inflammatories. One thing that we have used quite a bit over the years is evening primrose oil.
Oh, yes. Evening primrose is great for the hair and the breast tissue.
It just dawned on me.
Yeah.
So evening primrose or borage oil is providing the body an essential fatty acid called GLA, gamma-linolenic acid. But, omega-3 fatty acids and GLA, when you're trying to reduce inflammation of any sort, those are sort of like the go-to things. I had a hairdresser, a stylist. I'm not sure what the correct term is. Stylist. Yeah. What do you call your hair girl?
Yeah, stylist, hair designer,
yeah,
hair artist.
Yeah, I don't know. All the above. Well, she's busy. She got a lot of clients. She's on her feet all day long. Stress. Dealing with lots of people. It's challenging work. And she was always acutely aware, partially because of what she does for a living. Her hair was shedding all the time. Reverse back to 2020, COVID came along, and she was like on a forced vacation, because COVID, time with the family, stress level goes down. And then guess what? Her hair shedding basically stopped. Because she wasn't working. Now granted, that can create some other issues, right? I think it did for some. You're not making any money and you're not, generating any business that way. But stress level of her being overly busy sort of went from being really busy to not busy at all, and it didn't take very long, and her hair sort of just, or the excessive shedding. She never had any problem areas, kind of like yours. You don't have any problem areas, but she was concerned about the amount.
I don't have any. I mean, I have hair. I don't. My
You
hair's
don't have
okay.
any problem areas.
Okay,
No, no.
you're like you have problem areas. I
No,
don't
I
have
said
any
you.
problem.
No, I meant you don't. She didn't have any problem areas either, but she was concerned with the amount of the shedding she was having.
And because she knew there was a lot.
Yeah, just the,
And then
the
did it
volume
come
was
back
high.
now that she's back in her salon?
Well, yeah. Now it's now she's got that as a barometer that she even brought it to my attention. She goes, "Guess what? I've been on vacation for a little bit, and my shedding has gone down by 3/4." Like she noticed the connection. I didn't even have to bring it up. She brought it to my connection. So now she sort of uses that as a barometer as she's moving forward. Not that she's, my stress level, I'm noticing 3 more hairs. I'm going to, she's just trying to manage it a little bit differently because she knew that, or she figured out that it was definitely driving the, the hair loss because she was sort of on a forced vacation. So stress, that's the hard one
Stress causes everything.
it really does. That's a hard one to deal with, but that's something that there's not really a great medication treatment to directly affect something like that. So, anyways, yeah. Do you have any more things to add to hers?
There's probably so much more and things we haven't talked about, but I think this is good.
Well, the hair loss issue comes up a lot, so we're going to probably end up circling back around. This question will come out probably another 10 times, so we'll, and this is
there was another question. So this was from May at May Smith, and she was saying another one. Can you please make a video on HRT and hair loss, because she was on an estradiol spray that went to an estradiol gel and then on progesterone. So this is not uncommon. This is common, and of course we can say that because we see that a lot with our patients.
Well, I've prescribed the rhythmic dosing estrogen, progesterone for women that are dealing with the hair issue, just because you're raising those levels to a to kind of like a physiologic level. We've talked about rhythmic dosing. We'll talk about it again. That's why in a situation like both of those, I would probably lean that way a little bit because you're really pushing up those numbers quite a bit.
But you're cycling it. Yeah, you're right. At Stay Gold would probably do really well on the rhythmic dosing.
Yeah. Now, granted, that's not hot flashes. That's not night sweats. A lot of the static dosing is going to solve those issues. But when you're dealing with these other accessory issues of menopause, that's where you have to kind of pick the right approach that's going to solve those problems. So we'll definitely follow up with that because we always have more to learn, and hopefully if you have more questions, just put them down in the comments, and just keep the conversation going that way. I guess.
One thing, I know this is going on and on, but this has been really good, is, I went through all the YouTube comments, and we get a lot of Ask the Doctor questions on our website. We love this, and I'm trying to, and I found a lot about the hair, so that's why I said, let's talk about HRT and hair loss, because it looks like that's a theme here. So whatever your biggest issue is with menopause or perimenopause, please write it to us, because we just, we're inferring just from our patient practice, but we want to know from everybody, what is your biggest concern with perimenopause and menopause, so we can kind of find an overall theme to be able to help kind of direct this too.
Even if you're commenting on a video that you're talking about, your biggest concern is not what the video you're watching is about, just comment on it anyways, because we are monitoring.
Read them.
Yeah, we are monitoring all those. We don't have the time to respond to every single one of those, but we do, we are monitoring them all, so that way we can do things like this. And you're right, that hair loss thing has come up a bunch of times. The bleeding issues come up a bunch of times. I think there's a series of questions about melasma. There's a lot of, people asking the same questions. That's why it's good for us to know what people are interested in. Not necessarily what's trending, but we sort of know what women think they should know, but we want to know what you actually really want to know, because then everyone's benefiting that way, and we're providing as much value as we can. So write your questions in the comments. Until next time, I'm Dr. Mackey.
I'm Dr. Davidson.
Take care. Bye-bye.